From Redfield Medical Direction, I'm Lynn Nguyen, Associate Medical Director, and this is our Journal Club podcast, where evidence-based medicine meets EMS. We get to have Dr. Redfield with us today to talk about what I think will be one of the hottest research articles of this year. It was published February 12th in the Prehospital Emergency Care Journal, entitled Epinephrine in Prehospital Traumatic Cardiac Arrest, Life-Saving or False Hope? And the first question I have for you, Dr. Redfield, is there a difference between medical and traumatic cardiac arrest?
Dr. Nguyen, that's a great question, to be honest with you. Medical cardiac arrest often stems from electrolyte abnormalities versus stenosis in the arteries. When we look at that traumatic arrest patient, it's a different cause. Could be hypovolemia, hypoxemia, or mechanical issues affecting the heart function.
So what you're essentially suggesting is that the usual ACS protocols might not be as effective in trauma cases. What did the researchers in this article set out to investigate?
The goal of the study was to determine if Epi improves survival in patients with prehospital traumatic arrest. They also want to see if there's certain populations in the subgroup that would show benefit if you gave Epi or no Epi.
How do they go about figuring this out?
Well, to kind of dig into the details here, it was a multi-center retrospective cohort study, and it looked at 7 level 1 and 2 trauma centers over 6 years. That was from 2011 to 2017. They looked at over 1,600 adult and pediatric trauma patients who experienced prehospital cardiac arrest. Data was gathered from the trauma registries that they used in chart reviews.
That's actually a pretty big sample size, especially when it comes to pre-hospital research studies. What did they find?
I think no big surprise to most of us in the EMS community. They found that actually when you give epinephrine in traumatic cardiac arrest, you actually had poorer outcomes.
Given how often epi is used in cardiac in general, that's pretty surprising. Can you give us more details about the study?
Yes, I'd love to. The first thing that we kind of can point out is that only 5% of pre-hospital epinephrine group survived a hospital discharge compared to 16% in the no epinephrine group, which is a huge difference compared to what we're used to seeing. When you actually break down the actual types of trauma, blunt trauma appeared to be the biggest difference compared to penetrating trauma, and what it showed was 3% versus 16% of survivors at hospital discharge.
So based off the numbers you're just throwing off right now, it seems like epi is doing more harm than good in some situations. Did these researchers do any subgroup analyses and find any situation in which epi might be beneficial?
Not really. Epi did not improve survival in any of the subgroups they assessed, including those above 65, under 18 years of age, or those with a shockable initial rhythm. For patients with an initial shockable rhythm, survival was much lower in the Epi group. Why do you think Epi might cause a harm in traumatic arrest patients?
Well, like the authors alluded to in this study, the body's natural response to blood loss and trauma already involves vasoconstriction and increased heart rate. Epi is just going to overstimulate this response without addressing the underlying cause, which might be either volume loss, hypoxia, or just injury to the heart.
Dr. Nguyen, after reading this research article, how do you think this impacts our future?
Not to toot our own horn, but I do think that we are pioneers in this field because I think that this research study suggests that medical directors in general should be reevaluating their protocols with regards to traumatic cardiac arrest, and specifically with regards to the use of epinephrine and if it is actually at all useful in resuscitation of traumatic cardiac arrest. So based off these numbers and findings, this could really change how EMS approaches traumatic cardiac arrest. What do you think we should emphasize moving forward?
At this point, we all can agree on that Epi should not be routinely used in traumatic cardiac arrest. We should focus on life-saving interventions such as external hemorrhage control with direct pressure, wound packing, and tourniquets. Let me again emphasize this. Tourniquets, wound packing, direct pressure have been proven to be effective in this patient population. Airway management should be considered with the least invasive approach necessary to achieve and maintain adequate airway patency, oxygenation, and ventilation. If you consider tension pneumothorax, please needle decompress. Studies have shown in the past that this is one of the major reasons why people go into traumatic arrest that can be preventable by EMS. The next debate, hot topic, I think all of us will agree on, would be external chest compressions. And again, after we do life-saving interventions, one may consider this approach, but that is medical director independent.
I totally see where you're coming from, and I 100% agree. Thank you for breaking down this article for everyone and for me, and we'll see you next month for the next article.